Okay, so I think we can start. So, of course, today we'll just talk about the pathophysiology of heart failure, which is very, very important for cardiology. Most of the patients we see come with heart failure from different causes. So understanding the mechanism behind heart failure is very important to even understanding the management of patients. So by way of introduction, as we know, the current definition of heart failure, okay, 3 components. So it's a clinical syndrome, okay, with typical symptoms, okay, typical dyspnea, ankle swelling, and fatigue, and that are accompanied by signs, okay, and the important ones, raised JVP, pulmonary and peripheral edema. And it's caused by either a structural or functional cardiac abnormality. Okay, and that functional or structural abnormality leads to either a reduced cardiac output or an elevated cardiac pressure during rest or exercise. So that's the ESC-based definition of heart failure. So the structural and functional abnormality is very important, and how those structural and functional abnormalities come about is what we'll be concentrating on. So heart failure, as we all know, it's a progressive disease, okay, and the annual mortality rate about 10%. And in these patients, the main cause of death is sudden cardiac death, which accounts for more than 50%. Okay, and then also organ dysfunction due to hypoperfusion lead to death in these patients. So even for the diagnosis of heart failure, the demonstration of underlying dysfunction is very, very important. And you need that to make a diagnosis of heart failure. And so mainly the abnormalities that result in heart failure affect either systolic or diastolic function. Okay, that is the main function of the heart that is affected in heart failure. But however, several other factors can be affected and still lead to heart failure. So you can have abnormalities with the valves, abnormalities of the pericardium, problems with the rhythm of the heart and conduction can also lead to heart failure. But predominantly, the heart failure patients we see either have systolic or diastolic dysfunction. Okay, so being able to understand the pathophysiological mechanism that lead to heart failure is very crucial in terms of choosing the therapy. Okay, so for instance, if you have a valve pathology leading to heart failure, you know you're not going to help the patient much with just medication. You need to intervene to correct the valvular problem, to intervene and to help the patient. So understanding the mechanism causing the heart failure is very important for the appropriate management of the patient. So we'll talk about how heart failure has been classified over the years briefly before we delve into the pathophysiology. So the most common classification now, and a lot of publications that are coming out, are basing the classification of heart failure based on the ejection fraction. Okay, so if the ejection fraction is less than 40, then it is classified as heart failure with reduced ejection fraction, otherwise known as systolic heart failure. Okay, and if the ejection fraction is greater than or equal to 50, it is described as heart failure with preserved ejection fraction. So when the ejection fraction is between 40 to 49%, previously it was described as heart failure with mid-range ejection fraction. Okay, but further studies and understanding of the mechanisms of failure in these patients have revealed that those in the range of 40 to 49 are actually in a continuum leading towards a lower ejection fraction. So that nomenclature was changed recently to heart failure with mildly reduced ejection fraction. Because when you follow these patients, they tend to go into the overt reduced ejection fraction rather than to preserve ejection fraction. So the correct nomenclature now is mildly reduced ejection fraction instead of the previously used mid-range ejection fraction. Okay, so these tables just show the dominant causes of systolic and diastolic heart failure. Okay, know that hypertension can cause both, either one of them, depending on how the patient presents. Okay, and so your toxic cardiomyopathy mainly causes after this. And then on the other table value. Can you please mute? All right. And this table shows the causes of diastolic heart failure, which you will be good. So further classification, apart from the ejection fraction, can be based on the chronology of the heart failure. Okay, so you can have acute heart failure and chronic heart failure. So acute refers to either rapid or gradual onset of symptoms and signs of heart failure that are severe enough for the patient to seek urgent medical attention. Okay, and that can lead to an unplanned hospital admission or emergency department visit. Okay, so for the acute heart failure, you can have acute de novo heart failure, that is a new onset heart failure, the patient presenting for the first time with decompensation and needing admission. Or you can have an acute decompensation of a chronic heart failure. The patient who has had chronic heart failure, they are stable on treatment, but then something happened along the way, either compliance issue or an infection or any other stress to the system cause them to decompensate. And of course, chronic heart failure, they are stable patients with stable heart failure symptoms that has been there for months to years. Those are your chronic heart failure patients. It can also be previously heart failure has been classified based on the circulatory system affected. So we can talk about left heart failure and right heart failure. Okay, and these are some examples of predominant causes of right and left heart failure. Okay, and you must know that the most common cause of right heart failure is actually left-sided heart failure. It's not put in this list. The heart failure can also be classified based on the underlying pathology and pathophysiological factors. So you can have pressure-induced heart failure. Okay, so these ones mostly start with concentric remodeling because of the increased pressure, and then along the line, dilatation of the heart can occur. So arterial hypertension, aortic stenosis, and then volume-induced heart failure, mostly the regurgitant lesions and the intracardiac shunts. Okay, start with volume overload and progress. Okay, and then heart failure can also be classified based on the cardiac output to low output failure. Okay, and then high output failure. So in high output failure, mainly you have a mismatch between the cardiac output and the circulatory metabolic demands. Okay, so even though the cardiac output is high, it's still not enough to meet the demand. So you get this in conditions like hyperthyroidism or in conditions like anemia, when actually the oxygen carrying capacity of the blood has reduced. So even though the heart is working, pumping, but it is not delivering enough oxygen to meet the demands of the tissue. Good. So those are just an overview of the various ways in which heart failure has been classified over the years. But as I said earlier on, the predominant one that is used nowadays is based on the ejection fraction. And most of the studies that are coming out are centered around that classification. So the pathogenesis of heart failure, okay, as we've said earlier on, is a progressive disorder, okay, and most time it is initiated by an index event, okay? And when that index event happens, a lot of the time, the patient is not symptomatic at that point. But once that index event has happened, it will now trigger secondary damage and compensatory mechanisms. And then over years, over time, the patient will progress to become symptomatic, okay? So the ejection fraction will drop progressively. And then over the years, the patient can become symptomatic. Okay, so the event that initiate heart failure can either result in loss of function in myocytes, like a myocardial infarction, or just disruption in the ability of the myocytes to generate force, okay, like in the cardiomyopathies and other forms of heart failure. So once that event has been initiated, and then because the condition is progressive over time, changes happen until the patient becomes symptomatic, okay? And the index events that will initiate the heart failure, they can be abrupt in onset, like in a PE or an MI. And sometimes they can be very gradual and insidious. So your pressure and volume overload causes like arterial hypertension or a valvular heart problem. Okay? And also the index event may be genetic, okay, with your cardiomyopathy and the hypertrophic cardiomyopathy on stuff. So patients may harbor the gene, and that change has been there. And then over time, progress to become symptomatic heart failure. So the progressive model for heart failure, as you can see from this schematic, once the index event happens, it activates new hormones, okay? So increased activity of your sympathetic system, activation of the RAS, okay, increase vascular factors like endothelin, your atrial and natriuretic peptide, and even an inflammatory response. So once these are being activated, they can lead to secondary damage on the myocardium. So your remodeling, reduced contractility, hypertrophy. And once this secondary damage happens, they further enhance, you know, and intensify the neurohormonal response at failure. Okay. And then this neurohormonal response also acts on the endothelium, okay, and can cause peripheral vasoconstriction and release of reactive oxygen species, structural damage, and further cytokine release. And all these get positive feedback. They can lead to more stimulation of your neurohormonal system. At the end of the day, you get progression of the heart failure. Then the patient becomes symptomatic. Okay. So we start with the sympathetic nervous system as part of the first of the neurohormonal pathway that are activated. Okay, it is is a very important adaptation when the cardiac output drops. Okay, and it occurs very early in the onset of heart failure, right? And activation of the sympathetic nervous system is actually accompanied by concomitant withdrawal of parasympathetic tone. So this is important, okay? So it's not just the sympathetic nervous system, but also withdrawal of parasympathetic tone also contribute. And we'll talk about those ones later in the slide, and even some attempts that have been made to use modulation of this parasympathetic tone as a form of treatment for heart failure. So activation of the sympathetic nervous system will provide a short-term support to the heart, okay? And this one, in the short term, is actually, it's actually help to maintain, you know, the blood pressure and the cardiac output. But in the long term, if it continues unabated, then it can become maladaptive and worsen, you know, heart failure symptoms. So in patients who have advanced heart failure, the circulating level of norepinephrine is very high, about 2 to 3 times what you find in normal people, okay? And studies have shown that the levels of norepinephrine in the blood, in the circulation of heart failure patient actually predicts the mortality of the patient, it predicts the outcome. So it's a very important pathway that is stimulated in heart failure. So this one just shows the various pathways that are involved. So for the stimulation of the sympathetic nervous system, the afferent limb of the reflexes come from the chemoreceptors in the carotid body, okay, that sends high concentration of carbon dioxide and other metabolites in the blood. There are baroreceptors in the aortic arch and also carotid sinus. Okay, there are also baroreceptors in the myocardium themselves. Okay.
Hello, Dr. Conte. Your voice is undergoing pacemaker. Yes. All right. I don't know if you can start again with this particular slide. If you can start.
Yes. So this slide is showing how the sympathetic nervous system is activated. So on this left panel is showing you the afferent impulses, okay, that are sent to the cardiovascular center. So these impulses come from receptors in the cardiovascular system. Okay, so you have the chemoreceptor in the carotid body that senses the metabolites in the blood, so the carbon dioxide level in the blood and other metabolites can activate this receptor to send impulses to the cardiovascular center. Okay, and so for the chemoreceptors, it sends stimulatory. And once you have high carbon dioxide and metabolites, it stimulates these receptors and they send impulses to the cardiovascular center. Whereas for the baroreceptors, okay, so when the blood pressure drops, it reduces firing of these baroreceptors. And once the firing from the baroreceptors reduce, okay, they send impulses to the cardiovascular center, increase sympathetic output. Okay, it's the same thing with the baroreceptors in the atrium as well as in the ventricles, right? And then also metaboreceptors in the muscle, in the contracting muscles. Okay, when those carbon dioxide and other metabolites are high, this activates also the cardiovascular center. So all of these stimulus, they increase the sympathetic output. Okay, increase the sympathetic output through the sympathetic chain. But however, apart from increasing the sympathetic output, at the same time when sympathetic output is increased, parasympathetic output is depressed. Okay, so reduce release of acetylcholine at the parasympathetic or vagal innervation of the heart, which are mainly to the SA node and the AV node. So there is reduced vagal stimulation, but increased sympathetic stimulation. So when sympathetic stimulation is increased, norepinephrine is increased, okay, in the circulation and within the heart. However, when you have sustained release of norepinephrine, the norepinephrine stores are depleted. That's why you're seeing this arrow coming down. So this is referring to the stores of norepinephrine. They are depleted when you have excessive stimulation. And then also within the myocardium, when you have excessive stimulation with, of the sympathetic pathway, the sensitivity to norepinephrine also falls over time, right? And then apart from the heart directly, other areas where the sympathetic stimulation produces effect, importantly, is the kidney. So in the kidney, there is increased sodium reabsorption, increased production of renin, and also increased resistance in the renal vasculature. Okay, that happened. And then peripherally also, through stimulation of alpha-1 receptors in the vascular system, you have increased peripheral resistance as well as increase in the smooth muscle cell in the media of the vessel. Okay. So this other schematic just shows the individual effects at various levels in the heart and in the kidney and in the vasculature, as I've explained. So those are the effects of the sympathetic nervous system stimulation. Now, so parasympathetic withdrawal, as we said, also contributes to the pathogenesis. Okay? And when you have parasympathetic withdrawal, it causes decreased nitric oxide production, which we know is potent vasodilator. So when
hello, Dr. Conte. Hello.
It's gone faint again.
It seems when you change the slides, the voice changes. I'm not sure if I'm correct.
Yeah, the slide is going with the rhythm of the voice.
Yeah, it has this tandem nature, like the right and left side of the heart is working in series. All right, thank you so much. Just to crack jokes. All right, I don't know if you can come close to the system if you are not using your earpods.
Yeah.
All right, thank you, sir. Grateful.
Yeah. So, when the sympathetic impulse to parasympathetic, it can lead to decrease nitric oxide. It also increase inflammation. Okay, and then because of the withdrawal of the parasympathetic.
Sorry, we can't still hear you, Dr. Conte.
I think we are still having the same challenge. Don't know if it's our village network, but I don't know if you
Probably this
if
one
you
is
adjust.
likely this network issue.
All right, okay. You know, two of us, we have one village network system. All right, okay. No, thank you so much. So, yes, it comes in pulsatile fashion. But let's try and see. Let's try and see. Let's try and see.
Yeah.
And go ahead, sir.
Yeah. So when you have withdrawal of this, it further increases the sympathetic activity. Remember when I showed you the innervation of the heart, that the sympathetic nerve innervating the heart, you also have a presynaptic alpha receptor, okay, that can be stimulated by adenosine and the parasympathetic system to reduce sympathetic outflow. So when you withdraw the parasympathetic outflow, because of that loss of inhibitory effect, it further potentiates sympathetic activity, okay? And then parasympathetic withdrawal has also been shown to worsen left ventricular remodeling. Parasympathetic inactivation also plays a part in the pathophysiology, okay? And they've done clinical trials with vagal nerve stimulation, okay? They did not meet their primary endpoint, but they showed encouraging points. So in mortality or cardiovascular mortality have not been met, but some improvement in symptoms and reported quality of life has been shown in some of these trials. All right, now we go to the renin-angiotensin system. So the renin-angiotensin system is activated a little later. So the first is the sympathetic system. Then later on, the renin-angiotensin is activated, okay? So the mechanisms for activating the RAS system include hypoperfusion of the kidney, okay? And then reduce filtration of sodium, okay? And when that reduced amount of sodium reaches the macular denser cells in the distal tubule, it stimulates the release of renin, which starts the whole cascade for the production of angiotensin. Okay. And then also increased sympathetic activity. So activation of the sympathetic system, like I showed you earlier on, can also activate the renin-angiotensin system. Okay. And once this system is activated, it leads to increased secretion of renin from the juxtaglomerular apparatus. Now, this schematic just shows the production of angiotensin. Okay, so angiotensin is secreted mainly by the liver, the one that is in the circulation, but also some amount of angiotensin is also secreted by local tissues. So within the heart, the brain, the kidney, and the vasculature, some amount of angiotensin is secreted. Okay, so the angiotensinogen is converted to angiotensin 1 by renin. Okay, so in the circulation, it is mainly converted by renin produced in the kidney. Okay, and then the ones that are secreted in the tissue, they are mainly is mainly converted to angiotensin 1 by tissue renin. Okay, and other proteins, other enzymes like cathepsin G and kallikrein can also help in the conversion of tissue angiotensinogen to angiotensin 1. Okay, and then we know that angiotensin 1 is not active. It's not the active hormone. So it needs to be further converted to angiotensin 2. So the angiotensin in the circulation is mainly converted to angiotensin 2 by angiotensin converting enzymes secreted by the lungs. Okay, whereas that in the tissue is mainly converted by tissue ACE, okay, and other proteases that can cleave angiotensin 1 to form angiotensin 2. Okay, so when angiotensin 2 is formed, it has various effects in the cardiovascular system, which we're going to talk about in subsequent slides. Okay, but at this point, you should know that this angiotensin 2 is inactivated by further degradation by proteases. Okay, it can be degraded into inactive fragments. Okay, but some of the proteases can also degrade it into other active fragments like angiotensin 3, angiotensin 4, and angiotensin 1-7. Okay, angiotensin 4 has not been shown to have much effect in the cardiovascular system, but angiotensin 3 and angiotensin 1-7 have effects. In fact, beneficial effects in the cardiovascular system, as we'll see in subsequent slides. All right. So angiotensin 2, which is the active form, okay, exerts its action to angiotensin receptors, okay? And these receptors, they are G protein coupled receptors. Okay? And in terms of the action of angiotensin, there are mainly two: angiotensin receptor 1 and angiotensin receptor 2. Okay. In the vasculature, the predominant receptor is angiotensin receptor 1. Okay. And in the heart, you have both angiotensin receptor 1 and angiotensin receptor 2. Okay. And interestingly, it is angiotensin receptor 2 that predominates in the heart. Okay, in a 2-to-1 ratio when you compare angiotensin 2 to angiotensin 1 in the heart. Okay, and as we'll see later, that the angiotensin 2 receptors, when they are stimulated, okay, the AT2 receptor, they actually have beneficial effects. So they cause vasodilatation and reduce mitosis in the myocardium, right? So activation of AT1 receptor, they lead to vasoconstriction, as I said, they lead to cell growth, further aldosterone secretion, and catecholamine release. Okay, whereas activation of angiotensin receptor 2 lead to vasodilatation, inhibition of cell growth, natriuresis, and bradykinin release, which is also a vasodilator. Okay. This schematic just shows you the many effects of angiotensin. So when it interacts with its receptor, it is internalized through signal transduction. In the vasculature, it can cause contraction. In secreting tissue like the adrenal gland, can cause secretion of hormones. Okay. Apart from this immediate action, they have long-term action through gene regulation. So they can upregulate the production of angiotensinogen, renin, ACE, okay, and then also upregulate the production of angiotensin receptors themselves, okay. And also, apart from these effects, they can be internalized by the cell for degradation, okay. So angiotensin 2 can be degraded both intracellularly and extracellularly, all right. So they can be internalized as well for degradation. All right, so this schematic just shows the effects of angiotensin 2. Okay, so when it acts on AT1 receptor, that's when it produces the bad effects that we don't want in heart failure. So vasoconstriction, okay, sodium and water reabsorption, inflammatory response, hypertrophy and hypoplasia, cell proliferation, as well as oxidative stress. This is very important, the oxidative stress, because it's central in causing damage to the myocytes themselves and leading to irreversible heart failure. All right. But when angiotensin acts on the AT2 receptor, when angiotensin 2 acts on the AT2 receptor, beneficial effects we see. So vasodilatation, anti-inflammation, apoptosis, anti-cell proliferation, and then antioxidative stress. All right. Angiotensin 1-7 can act through receptors that are called MAS receptor, mass receptor. Okay, and when it acts through this mass receptor, produce beneficial effects, vasodilatation, diuresis, anti-hypertrophy, and nitric oxide release. Okay, so AT1 receptor is the bad receptor. It's what sort of cause the production of the harmful effect of angiotensin 2. Okay, and that is why you can see why the angiotensin receptor blockers that block angiotensin 1 would have real beneficial effects, because apart from stopping the AT1 effect, they can also leave the AT2 and MAS receptor effect unabated. Okay, whereas when you block it at the ACE level, okay, you block everything. So both these deleterious effects and then these good effects are all blocked. And so that's an important thing to take note of. All right. Now, aldosterone, which is one of the hormones that is further stimulated by angiotensin 2. Okay. It also provides short-term support to the circulation, and this it does by promoting sodium reabsorption and potassium in exchange for potassium, so potassium secretion in the nephron. Okay, and this it does in an attempt to increase intravascular volume because it is sensing low cardiac output or low blood pressure, so it is attempting to retain water to restore. Okay, but however, when this is sustained, okay, aldosterone has many harmful effects. Okay, and this happens through hypertrophy and fibrosis in the vasculature and the myocardium. Okay, endothelial cell dysfunction, baroreceptor dysfunction, and inhibition of norepinephrine uptake. Okay, because normally when norepinephrine is released in a normal functioning nerve cell, a lot of this is taken up by so that the effect is not perpetuated. So when you have increased aldosterone, it reduces the uptake of norepinephrine, so further perpetuating the sympathetic overstimulation. Okay. And the way aldosterone acts in the cardiovascular system, they've shown appears to involve oxidative stress. Okay. And when this oxidative stress happens, it's finally results in inflammation in the target tissue. That's why aldosterone is one of the key hormone that is implicated in the fibrosis that occur in chronic heart failure. And once this one sets in, it is no longer reversible. Okay. So let's talk a bit about oxidative stress. Okay. So these reactive oxygen species, they are actually produced within the cell during normal aerobic metabolism. Okay. Within the mitochondria, even the xanthine oxidase, when it oxidizes the xanthine molecules, they produce reactive oxygen species. Okay. Even in the oxidation of NADH to NADP, okay, also produce reactive oxygen. But in the normal human being, there are cofactors that help to reduce this oxygen, reactive oxygen species. Things do biopterate and 5-hydroxy tetramethyl folate. Okay, so the folates they are the hazardous effect of this reactive oxygen species. So in heart failure, there is increased production of overwhelm the natural antioxidants. And so high concentration of this in reactive oxygen species, effect of the cell is disrupted. So from the membrane receptors, they are affected. Okay. The calcium channel are affected, the sarcoplasmic reticulum. ATPs are also affected, the ryanodine receptors. They all malfunction in the presence of reactive oxygen species. Even the sarcomere, the myosin and actin, okay, their contractile effect reduce in the presence of reactive oxygen species. Okay. There are even certain genes that are transformed to oncogenes because of reactive oxygen species. Okay. The expression of certain growth factors also happen when you have reactive oxygen species and promoting remodeling within the heart. So these reactive oxygen species, they are central in disrupting the normal functioning of the heart and even structurally affecting the heart, leading to adverse remodeling. Okay. So when you have heart failure, these reactive oxygen species, they are increased both within the heart and systemically in the entire system, okay, and therefore causing abnormal function. And they're saying this increased inflammation and reactive oxygen species are what are responsible for the cachexia that you see in patients with chronic heart failure. So briefly, we talk about the effect of the neurohormonal activation on the renal system. Okay. So if you see here, once the sympathetic system is stimulated based on input from the various receptors in the heart, so the baroreceptors and chemoreceptors afferent to the cardiovascular center, and then the efferent goes through the sympathetic chain. Okay. And those sympathetic effects on the kidney cause increased production of renin, sodium and water retention. And then renin production ultimately leads to activation of angiotensin with all the effects that we've talked about. But apart from the sympathetic pathway, there can be direct stimulation of the kidney, okay, through the posterior pituitary by the secretion of arginine vasopressin, okay, which is an antidiuretic hormone, act on the distal tube to cause further retention of water. All right. And of course, we know that the sympathetic nervous system also acts on the vessels, okay, cause vasoconstriction, as well as through angiotensin, cause also potentiating the vasoconstriction. All right. Now, the reduced output from this baroreceptor, which activates the cardiovascular center to release sympathetic output, okay, have been looked at to see how this can be modulated, you know, as a form of treatment for heart failure, okay? Because when the blood pressure is low, there is loss of inhibitory input from these receptors. So there is constant stimulation of the sympathetic center. So what they've tried to do is to mechanically stimulate these baroreceptors. So they've used implantable baroreceptor stimulating devices that will activate these carotid baroreceptors, okay? The baroreceptors in the carotid sinus, okay? And once they are activated, they will decrease the sympathetic output from the cardiovascular center, okay? And initial studies have shown that when these devices are used to stimulate the carotid baroreceptor, they actually improve the quality of life and exercise capacity of patients with symptomatic heart failure. Okay, so because of this initial positive preliminary effect, they've been able to obtain expedited approval from FDA, and they are now doing a large randomized clinical trial called the BEAT-HF trial, wherein they're using barostimulation therapy in heart failure, okay? And this trial now that they're doing will determine whether this barostimulation will favorably affect cardiovascular and heart failure mortality, okay? So we should be on the lookout for this. This might add to the device therapy for heart failure, in addition to your ventricular-assisted device and resynchronization therapy. So barostimulation therapy is something that is on the way. Now, importantly, there are other hormones that are called the counter-regulatory hormones, okay? These are good and desirable hormones for the cardiovascular system when the cardiovascular system is challenged, as in heart failure, okay? They become activated in heart failure to offset the effect of the vasoconstricting hormones like your angiotensin 2, okay? And they include two sets of hormones. So the natriuretic peptides, which include both atrial natriuretic peptide and the B-type natriuretic peptides, okay? And then the vasodilatory prostaglandins. So mainly prostaglandin E2 and prostacyclin, which is prostaglandin I2, okay? Now for the prostaglandins, you know, apart from their vasodilatory effect, specifically prostaglandin E2 also causes renal excretion of sodium, and then it modulates the effect of antidiuretic hormone on the kidney. So it reduces the antidiuretic and favors the excretion of water. So they are very good and help to protect, you know, the cardiovascular system in the face of an overstimulated sympathetic system and RAS system. However, when you have heart failure, the sympathetic system and the RAS system, they overwhelm these counter-regulatory hormones. Okay, they overwhelm these counter-regulatory hormones, mainly because these counter-regulatory hormones, they do not have a long duration of action in the blood. They are quickly metabolized by enzymes that we'll talk about. So their effects do not last long, and they are overwhelmed in the normal system by the sympathetic nervous system and the renin angiotensin aldosterone system. So a little bit more on the natriuretic peptide, which are very key in heart failure. Okay, so both of them, ANP and BNP, are secreted in response to increased cardiac wall tension. So once there is wall tension or stretch in the myocardium, both the atrial and ventricular myocardium, can lead to secretion of this natriuretic peptide. Okay, so the atrial natriuretic peptide is actually secreted in short bursts, okay, and it responds to acute changes in atrial pressures, all right? While the BNP, its fission tends to be activated through transcription of proteins. So it actually produces a more chronic, later response to chronic increase in atrial and ventricular pressure. So acutely, when the pressure rises, it is ANP that is secreted. But when that pressure rises sustained and it becomes chronic, then transcriptional changes occur within the myocyte and produce and favors production of BNP. Okay. So in the setting of heart failure, when RAS is activated, your ANP and BNP, they serve, as we said, as important counter-regulatory hormone because they counter the effect of your RAS stimulation, okay? And they help to maintain the sodium and water homeostasis because your RAS system will favor more retention of sodium and water, whilst your counter-regulatory hormones favor the excretion of sodium and water, okay? But however, as we said, as heart failure advances, the effect of the natriuretic peptide are blunted, they are overwhelmed, and then they leave the effect of RAS unopposed. Okay, this schematic just shows into a little bit more detail the action of this natriuretic peptide. So you have natriuretic peptide receptors, and they are the receptors and natriuretic peptide A, B, and C. Okay. So natriuretic peptide receptor A and B, natriuretic peptide receptor A is the one that is the receptor for ANP and BNP. Okay, ANP and BNP, they act via natriuretic peptide receptor A. Okay.
Sorry, Conte, we can hardly hear you again.
Oh, okay. Sorry. So ANP and BNP, they exert their action through natriuretic peptide receptor A. And though this natriuretic peptide receptor A,
Dr. Conte, I think
yes,
the village people have started again. I don't know if you can shift a bit. Let's see. But you're doing a great job. Thank you so much. Thank you. So you can try it. Let's see.
Is it better now?
It's not better per se, but we can hear your voice. Yeah, it's better now. So let's try and see.
Fantastic. All right. So as I was saying, there are three types of natriuretic peptide receptors. Okay. So the ANP and BNP, they exert their effect through natriuretic peptide receptor A. And the receptors, they are G protein linked receptors. Okay. And when they are activated, they result in natriuresis and diuresis, as we said, vasodilatation, and then they inhibit the right. C-type natriuretic peptide actually produce its effect through natriuretic peptide receptor B. Okay, it's also dilatation. All of these A-type natriuretic peptide, B-type natriuretic peptide, and C-type natriuretic peptide, they are into the cell through natriuretic peptide receptor C, natriuretic peptide receptor C. And when they are internalized, they are degraded. Okay, and insulin degrading enzyme within this lysozyme is what degrades them intracellularly. Okay, that's how they are degraded intracellular. Cellular fluid also potent, is very efficient in degrading this natriuretic peptide, and their action is not long in the system. Okay, and one of those neutral endopeptidase is actually neprilysin. Okay, I'll talk about it later on. Good. So this one just shows that the degradation of your natriuretic peptide. Okay, so all three of the natriuretic peptide that are important in the cardiovascular system, okay, they are degraded by two major mechanisms. Okay, so the intracellular mechanism, okay, that happens through natriuretic peptide receptor C. So once they bind to the receptor, they are internalized, okay, and then they are degraded in the lysosome by insulin degrading enzyme, okay, and then in the circulation, they are degraded by the neutral endopeptidase neprilysin, and this is widely expressed in multiple tissues. All right. Good. So if you look at this diagram, that's what it is. So this is neutral endopeptidase degrading the extracellularly by cleaving the ring, whereas in the lysosome intracellularly, they are degraded by insulin degrading enzyme. So they cleave the tail and inactivate the natriuretic peptide. Okay. Apart from the effect of the natriuretic peptide in this degradation of the natriuretic peptide, the neutral endopeptidase, apart from degrading the natriuretic peptide, they also degrade other substances. So for instance, bradykinin, okay? So when they degrade bradykinin, okay, because of degrading bradykinin and the natriuretic peptide, you would have vasoconstriction, because ordinarily these molecules produce vasodilatation, diuresis, and they prevent fibrosis. So when they are degraded by neutral endopeptidase or neprilysin, then you get this deleterious effect, okay? But also these enzymes can also degrade angiotensin and endothelin as well, okay? And when they degrade this one, since normally they produce vasoconstriction, okay, when they are degraded, you get vasodilatation, okay? The neutral endopeptidase in the CNS, they also degrade amyloid beta peptides, they degrade opioids, they degrade enkephalins as well, okay? So if you have very widespread, inhibition of this enzyme, you can have a lot of deleterious effects, especially in the CNS, okay? In fact, they've shown that some studies have shown that activating CNS neprilysin can actually prevent Alzheimer's in some patients because it helps to degrade amyloid beta peptide, all right? So you don't want widespread degradation of your neprilysin, especially in the CNS, okay? So most of So in the development of medication to be able to harness the beneficial effect of the natriuretic peptide, it was challenging because of these other effects, of other molecules that are degraded by neprilysin, okay? So they had to look for molecules that are selective and that cannot cross the blood-brain barrier, that cannot go into the CNS, okay? So what they ended up with that worked very well was to combine an angiotensin 1 receptor antagonist with neprilysin. So it makes the molecule big, not cross the blood-brain barrier, and then you can block the angiotensin 81 deleterious effects and leave the good effects of 82, and then also block the degradation of the natriuretic peptide and get the beneficial effect of the natriuretic peptide. So that's how this combination of 81 receptor and neprilysin inhibitor in valsartan sacubitril had very favorable impact, okay, in heart failure. And in the trial, in this paradigm trial, this combination actually showed superiority to ACE inhibitors. Okay, it is more superior because you are combining AT1 effect as well as the effect of natriuretic peptide in heart failure. Okay. So how about the effect in the peripheral circulation of this neurohumoral activation? Okay. So you have very complex interaction between the autonomic nervous system and the local autoregulatory mechanism, okay, in heart failure. And once when all of this happen to sort of preserve the circulation to major organs, so the brain and the heart, while reducing blood flow to the non-essential organs. So you get excessive vasoconstriction in the skin, the skeletal muscle, the splanchnic circulation, and the kidney. But then you maintain blood flow to the heart and the brain. Okay, and this come about as a result of a complex interplay between your autonomic system activation as well as local mechanism within the vasculation itself. So substances released by the endothelium, okay, especially endothelin, causing vasoconstriction in the non-essential organs. So the most powerful stimulus for peripheral vasoconstriction is the sympathetic activation, okay, which releases norepinephrine, all right? And when sympathetic adrenergic stimulation is increased in the peripheral circulation, it causes vasoconstriction in the arteriole, okay? And when you have arteriolar vasoconstriction, okay, it increases arterial blood pressure and it helps to maintain arterial blood pressure in heart failure. You know that systemic peripheral resistance is mainly contributed by arteriolar smooth muscle. So when they are stimulated by the sympathetic system, they help to maintain your systolic blood pressure. Okay, but also apart from stimulation of the arteriolar system, the venous system is also stimulated, and vasoconstriction actually results in increased, venous return. Okay, which increase your end-diastolic volume, and this end-diastolic volume, once you increase it, it will stretch the myocyte, and from the Frank-Starling principle, when you get the myocyte, you expect to get better contraction. Okay, so you see that these effects are actually intended to compensate. Okay, but in a failing heart, with all the other effects going on, you actually do not end up having increased cardiac output, but instead, the Frank-Starling relationship does not, does not work well in the failing heart. So instead of you actually having increased cardiac output, when there is sustained stimulation, you end up having reduced cardiac output. Now, I've put these substances here because they're very important, and these are potential areas for MCQ. Okay, these are all substances that are on the peripheral circulation. Okay, so we have the vasoconstrictors and the vasodilators, okay, that interplay to produce the effects we see in heart failure. So in the peripheral circulation in heart failure, the vasoconstrictors predominate, okay, and they overwhelm the vasodilators. So the vasoconstrictors, the catecholamines, when they act on alpha-1 adrenergic receptor, okay, and the vasculature, they produce
So Conte, it seems the network is giving us switches again. But then let's see, it will be fine. It seems when we interrupt, it comes back better. Then let's try and see.
All right. So, so the catecholamines
this why it has gone totally. This is like when NAD declares strike. So let's see. You shift a
Are
bit.
you getting me now?
Yeah, better.
Okay. All right. So these are
We're not getting you at all.
Not hearing you again, no.
hey, trouble. Oh. Are you
Okay.
getting me now?
You can hear
Yeah,
you
It's
now.
better now.
We'll
Yes.
get to you and then it goes up.
I don't know why the network.
Oh,
is
let's
misbehaving.
try it and see.
We'll just have to let you know anytime.
Let's try it and see.
Okay.
Can you just let's try and see.
Yes. Is it better now? Is it better?
No, it's not. Can you shift a bit? Or is there any other location that was functioning before now? Well, great job.
Okay.
I'm enjoying every bit of it.
Just 1 minute.
It's not clear. Hello.
How about now?
Yeah, it's perfect. Let's hit the ground running. Oh, it's been long ahead
Good.
without sound of hitting the ground running.
Yes. Yes. Okay. So these are vasoactive substances that are involved in heart failure in the peripheral circulation. So, sorry. So, in heart failure, the vasoconstrictors predominate in the peripheral circulation, while the vasodilators are overwhelmed. Okay. So the peptide vasoconstrictors include angiotensin, angiotensin 2, arginine vasopressin. So this, in addition, antidiuresis, it also causes vasoconstriction. Of course, endothelin, mainly secreted by the endothelium, neuropeptide Y, and then vasoconstrictor thromboxane. Okay, so remember, thromboxane is I can imagine an MCQ saying all the following, and they just put thromboxane in there. Okay, so remember this one is a lipid, and these are all peptides. And then the same thing classified. Catecholamine can also be vasodilators. So when they act on alpha-2 receptors centrally, okay, because this alpha-2 receptor centrally reduce the release of norepinephrine, so friction through that mechanism. And also, if they act on beta-2 receptors, they produce vasoconstrict dilation. Sorry. And then dopamine also is a vasodilator. It's a part of the catecholamine that are vasodilator. And then the peptides, the vasodilatory peptides, bradykinin, adrenomodulin, okay, apelin, all right? And then for the gases, nitric oxide, chief amongst them. And then for the lipids are your prostacyclin and prostaglandin, okay, which are main components of your counter-regulatory hormones. Good. Now, the inflammatory mediators. So apart from the countervailing hormones, okay, inflammation happens. We've spoken about oxidative stress, okay? So oxidative stress also causes the release of inflammatory mediators like your interleukin-6 and the tumor necrosis factor. They are also released in heart failure, okay? I've just listed the effects of these inflammatory modulators in remodeling. So they can alter the biology of myocytes. They can cause hypertrophy, fatal gene expression, negative and positive effects, increase oxidative stress. Okay? They can also alter the biology of non-myocyte structure, so the connective tissue within the myocardium. Okay? So they can cause conversion of fibroblasts to myofibroblasts, upregulation of AT1 receptor on fibroblasts, causing increased fibrosis, increased matrix metalloproteinase secretion by fibroblasts, causing degradation of matrix protein. Okay? They can also alter the extracellular matrix, okay, by degradation and then fibrosis, and then progressive myocyte loss, especially your tumor necrosis factor, causing necrosis and apoptosis. So all these effects contribute to remodeling, which is what we're going to talk about now. Right? So remodeling of the left ventricle. Okay, so remodeling is influenced by hemodynamic factors, neurohormonal factors, epigenetic factors, genetic factors, as well as other comorbidities. Okay, so if the person has, in addition to heart failure, they also have diabetes, they have renal failure, all of those can contribute to the remodeling that you see in the heart. Okay, and this remodeling traditionally has been described based on anatomic term, based on the morphology. But however, we know that the remodeling is not only limited to the morphology. Okay, it also improves alteration in the biology of the cell, alteration in the myocardium itself, as well as the structural alteration. Okay, so in terms of the biology of the cell, during remodeling, apart from what you see structurally, there is also alteration of excitation, contraction, coupling.
Hi, Dr. Conte.
Yes.
You're doing excellently well. We love every part of your discussion. The voice is not clear at this point. I don't know if you can switch.
Oh. Chivo copy.
Yeah.
It's like you are.
Yeah. You know the good side about it. The good side of the great side about this is that you are just. I wish that we had had these discussions with you. You're just answering MCQ questions and orals. And I know our prof, he likes these basics you are giving. So these things are very valid for our exams. So we just want to get the voice clearly so that we don't miss it. Can you try this?
Yeah, how is it
now? Not too okay, but it's improving. I don't know if you can switch it.
All right. Okay. I think yes. It should be
yeah, it's better. It's better. Let's try and see. Okay. I don't know if you can start. If you can start.
Yes. So this is about ventricular remodeling. As I was saying, several factors contribute to ventricular remodeling. So from hemodynamic factors, neurohormonal factors, sympathetic and RAS.
It's not. It's not. It's not clear. It's not clear. Yeah, I'm still having the same challenge. I don't know. Can we try something else? You have another network?
Not at the moment.
All right, I think it's getting clear. Let's try it.
Is it better?
Yeah, it's better. It just like comes and goes. I wonder what's happening from the village. It seems they know that this question is going to come out.
But is it better? Can you hear me? Can you hear me clearly?
Let's try. Yeah, fine. Better. Let's try.
Yes. So as we said, several factors from hemodynamic, neurohormonal, genetic and epigenetic factors. So changes in gene expression, okay, as well as comorbid condition all contribute to remodeling of the heart, okay? And even though traditionally we describe the remodeling based on the anatomy of the heart, but several aspects apart from the anatomy of the cardiac muscle are also affected in remodeling, okay? And some of the biological aspects of the myocyte that are affected include the excitation, contraction, coupling, okay, that we've talked about. So a lot of the processes are also affected. And then even the myosin chain. So in heart failure, remember we said that myosin heavy chain 2 is what is expressed in adults, and in fetal, in the fetus, you have more myosin heavy chain 1. When you have heart failure, you get increased expression again of the fetal form, the myosin heavy chain 1. Okay, and then desensitization of beta stimulation. So you get down regulation of the beta receptors in the heart. Okay, and that's how they become less sensitive to beta stimulation. lysis of organelles within the cell, okay, and also alteration in cytoskeletal proteins. All of these occur within the myocyte, okay. In terms of the myocardium itself, can get loss of myocytes, okay, necrosis, apoptosis, autophagy, okay, and then alteration of the matrix protein by degradation as well. And then the geometry of the ventricle is also affected, where you get dilatation and increased sphericity. So instead of the ventricle being an ellipse, it becomes spherical, and that affects, the wall stress and alter the performance of the heart. Okay, left ventricular wall thinning, remember from Laplace rule. So when the wall thins, it increases wall stress as well. Okay, and then valvular incompetence because of the dilatation. So you get a functional incompetence of the valves that are involved. So this schematic just shows the process of remodeling. Okay, how you respond to dynamic overload, right? So on this left side, showing you pressure overload, and on the the right side, volume overload. Okay, so when you have pressure load, there is systolic wall stress. Okay, and when you have volume overload, there is increased diastolic wall stress. Okay, and those stresses, they are sensed by mechanical transducers. Okay, one of them is the molecule titin. We said when we are looking at the heart as a pump, we mentioned titin. But apart from being a structural protein, can also transduce certain effects on the heart, like it can sense pressure and in the heart, and then use that to quote signals. Okay, so those mechanical transducers like titin transduce the signal and cause extra and intercellular signals as a result in remodeling. Okay, so mainly the pressure overload leads to parallel addition of myocytes and produce a concentric, hypertrophy. All right, whereas the volume overload produce series addition of myocytes in series. Okay, so therefore you end up with eccentric hypertrophy, wherein the internal diameter is increased, okay, as well as the wall thickness. All right, so when this remodeling occurs, so for both concentric and eccentric remodeling, they will all end up in a final common pathway when you actually have loss of the cell, and at the end of the day, dilatation will occur with ultimate reduction in systolic function. Okay, so normal remodeling or normal hypertrophy that you see in athletes will not progress to altered cell function or cell death. Okay, so when you have growth stimuli that is normal, it leads to physiologic hypertrophy. But abnormal stimuli like excessive pressure will lead to concentric hypertrophy initially, but later on will also lead to myocyte death and ultimate dilatation. Okay, so this same thing is emphasized here. Okay, progression of remodeling. So even though you start concentric, over time, dilatation will occur. Okay, and even when you start with dilatation de novo, over time, more dilatation occurs. So they all end up at the same tail end of end stage heart failure. Okay, and this progression is influenced by certain comorbid factors, risk factors, and also other damaging factors that will influence the phenotype, what happens, whether you're going to have concentric or eccentric remodeling, right? And some of those risk factors are listed there, as you can see. Now, there is a self-amplifying effect of remodeling, okay? And that is depicted in the schematic there. So the structural changes that is remodeling, they contribute to worsening of heart failure. Okay, So when the myocytes change from an ellipse to a, we know there will be increased wall stress. And when there is increased wall stress, it puts more burden, energetic burden on an already failing. It is not able to produce more energy. And then you remodel again and increase demand for energy. So it's just a positive sort of feedback. The remodel is itself. Okay. And also, when you have increased remodeling, afterload is also increased on the heart. So afterload is increased to damn the heart, requiring more energy utilization by the heart, okay, activating growth factors and all, and ultimately leading to fibrosis. So this diagram just depicts that. So you have increased energy utilization, okay, because of the increased energy utilization in a heart that is not efficient in producing energy, you get energy starvation. It can lead to cell death, necrosis, causing more remodeling, okay? If you have maladaptive hypertrophy, it can start concentric, okay? But because of decreased ATP generation in that heart, cell death can occur, more necrosis, more remodeling, okay? Myocardial stretch can lead to release of growth factors, okay? It can cause degradation of your extracellular matrix, can also cause apoptosis of the cell, can lead to further remodeling. So all of these processes are self-perpetuating because further adverse remodeling and lead the patients to worsening heart failure. Okay? So the remodeling process of itself is self-amplifying. Once it starts, it just continues. All right, so the alteration in excitation, contraction, coupling. Okay, we mentioned it earlier that this in the remodeling, it's not only the anatomy, but function processes within the cell are also affected. I think this schematic, we came across it before, okay? This is the force frequency relationship, okay? Or otherwise known as the staircase effect or the triple effect. Okay? So in a normal heart, when you increase rate, contractility should increase. But in the failing heart, wherein remodeling has occurred, you increase rate, the contractility reduce drastically, okay? So when you have higher heart rate, it results in more depressed, contraction. So you have a depression of your force frequency relationship, okay? And also, in heart failure, all of these proteins that we spoke about, they are affected, okay? First of all, when you have heart failure, you get increased cytosol calcium concentration, okay? The calcium concentration in diastole is increased. So when you have that increased diastolic calcium concentration, it causes reduced activation of your ryanodine receptor. So the ryanodine receptor, when they're activated, they do not release high amount of calcium because there is a resting high concentration of calcium, okay? The failing heart also have poor performance of the sarcoplasmic reticulum calcium ATPase, which is responsible to take away the calcium during relaxation. So both contraction as well as relaxation, they are both affected, okay? And also because of the reduced or inefficient energy production by the heart, your sodium potassium ATPase pump, they are affected, okay? And when your sodium potassium ATPase pump are affected, your intracellular sodium is increased, okay? And when intracellular sodium is increased, it has deleterious effects. It makes the heart, it puts the heart in a state where it is easily stimulated because you are already moving the resting potential towards the threshold potential when the calcium intracellular sodium is increased, okay? So little stimulus can stimulate the heart. So that is a recipe for development of arrhythmias when your intracellular sodium increase. So that happens in patients with heart failure. And also your electron transport chain is all affected in heart failure because of your reactive oxygen species, which we have talked about. They affect your energy production and as well your ATP production. And all of the reduced amount of ATP will definitely affect the actin and myosin region. Okay, so all of these processes within the myocyte, they are all affected. So there is decreased amplitude of intracellular calcium, there is prolonged decline of calcium transit, and there is increased level of diastolic calcium. All of these lead to both systolic and diastolic dysfunction in the heart. So now, let's talk about reversibility. Is it possible to reverse all of these changes that are happening in the heart, in heart failure? Okay, so clinical studies have shown that medical and device therapy that reduce heart failure morbidity and mortality, they also lead to reduced volume, and they restore the more normal elliptical shape. So they can actually reverse the remodeling, the adverse remodeling that has occurred. Okay, so the summation of all of these events, biological events that happen, changes in the myocyte size and function, okay, and a shift of the volume relationship towards normal, all of these changes collectively are referred to as reverse remodeling. So the reverse of what happens in heart failure. Okay, so the heart can undergo reverse remodeling either spontaneously or after intervention with medical or device therapies. Okay, so the heart can undergo reverse remodeling. Okay, and when reverse remodeling occurs in a patient, okay, there can be two outcomes. The patient can become free from heart failure events, okay, or recurrence can occur in a patient that has undergone reverse remodeling. So it's very important. That is why most times, once a patient is in heart failure, they have to be on the medication for life. Even if they have undergone reverse remodeling and they are not symptomatic, there is a possibility that they can get recurrence. Okay, and that takes us to differentiating between myocardial reverse remodeling and myocardial recovery. A lot of the time, people use them interchangeably, but they are different. Okay, they are different. So myocardial recovery happens when you have normalization of the molecular and cellular, as well as myocardial function, okay, with freedom from future events. Okay, so you have recovery, and then you're not at risk of suffering any future event. That's the time we use the term recovery. Okay, but if you have reverse remodeling and you still have a risk for future decompensation of future adverse remodeling, then we call that remission. Okay, so remission, myocardial remission, refers to normalization of the changes associated with remodeling, but they are not sufficient to prevent heart failure when you have abnormal hemodynamic perturbation in the heart. Okay, so you have some recovery, but then some structural damage, permanent damage has occurred that still puts you at risk of decompensation. Okay, so therefore we say you are in remission when you have a reversal of the heart failure phenotype in a heart that has already suffered permanent damage. Okay, you recover from symptoms, but permanent damage has occurred in the heart, then we say there is remission. But when you have recovery, it's when you have remission of heart failure symptom without any permanent damage to the heart. Okay, then that is remission. So, for instance, if you have an acute myocarditis, that causes low systolic function, overt heart failure, the patient is admitted, but then it is treated acutely and the patient recovers, cardiac structure and function goes back to normal and the patient is not at risk, then you can say that is recovery. Okay, that is recovery, myocardial recovery. But when you have things like myocardial infarction affecting a portion of the heart, okay, and then the patient goes into heart failure, but you are able to do revascularization and you're able to recover, but there is still a portion of the heart that has undergone cell death. You improve the patient function, you manage the patient, so that patient will have gone into remission, but the damage, permanent damage has been occurred, and if the patient goes without medication, they can have decompensation and present with overt signs of heart failure. So those are just little technical technical differences that we should be aware of. So finally, this slide just summarizes everything that we've talked about, and importantly, the interventions that can be done at the various stages in this whole pathophysiology of heart failure. So where your ACE inhibitors can act, your mineralocorticoid receptor antagonists, your angiotensin receptor blockers, blocking angiotensin 2, your beta blockers in the heart, and of course your neprilysin inhibitors blocking the natriuretic peptide. Okay, so this just summarizes everything that we'll be talking about and how you can intervene to treat the patient. And then this should be the last slide. It also shows the double effect, the double potent effect of sacubitril valsartan. Okay, no wonder why it has such a significant effect and very useful in patients with severe heart failure, because it blocks the deleterious effect of 81 and leaves the good effect of 82, supporting the heart. And then it blocks the degradation of your natriuretic peptide, okay, as well as other vasodilators like bradykinin and the others. So you get all the beneficial effects of this with this combination of neprilysin and angiotensin 1 receptor blockers. Okay. So that's it for the discussion. Those are my references. And we take questions and comments.
Wow, Conte, I will repeat again. I say that I bless the day that we pulled you out from the group. You are a blessing to Africa, not just to this group. And I'm just looking at the potential that you have in this cardiology field and how the people that will meet you subsequently as enjoy. It's a blessing to have you. And I would say that you answered a lot of questions in my heart, and I believe some other persons. Thank you for the time you used to prepare this slide, to internalize it, to give us the opportunity to partake of your wisdom. And also, I'm sure it's going to be beautiful. So with this, the floor is open. If you have questions and clarifications, please, you can unmute your mic and ask. You can just unmute your mic, ask questions, appreciation, just say one or two. It's a beautiful time to continue, right?
Thank you, Chief Okopi, sir. May I proceed, sir?
Yes, sir. Go ahead, sir. Yeah.
Okay, thank you so much, Chief Okopi. Chief Conte, I can't thank you enough. Thank you so very much. Your slides are so colorful. So, they mention yourself, thank you so much. This was in itself a revision course. It was because, as Fokupi said, I lost track of the number of questions, both in orals and this thing. There was actually even a question on this thing. What was it called? The sacubitril valsartan. You answered it. Yeah.
Hi,
So
continue.
thank you so very much. Now, I have a little question.
Yeah.
The patient suffers this index insult that results in a reduction in pump activity that then sets off this cascade of events that you have so waited upon. Then these events occur, they try to normalize the situation so that there is very little or no change in pump action. The question I have now is, so if the patient has remained compensated, what then tilts the patient? What then happens? Maybe, I don't know for what duration the patient may have been compensated, but what then happens to alter the hemodynamics in such a way that the patient then enters into failure? That's what I was wondering. Because we have patients who had an index event, and then all this cascade of events rallied around to, occur. Patients then stabilize for a while, and then suddenly you just find the person one day just tilts into failure. So I was just wondering that what happened to the system, this cascade of events that had been a rescue to the system up till that time. But thank you so much for this presentation, sir.
Okay, so several things do happen to cause the patient to decompensate again. So first of all, as I mentioned somewhere in the presentation, the index event can be an acute event like MI or PE, what they can do, and then it can be chronic insidious event. Okay, and so when they are chronic insidious event, the insult is ongoing. So like for instance, with hypertension, the high blood pressure is still there. So once the insult is still ongoing, it perpetuates the stimulation of this compensatory mechanism. And those compensatory mechanisms are beneficial only in the short term. If you continue to stimulate them and activate them in the long term, as we see from the remodeling, they will produce structural changes in the heart, that structural and functional changes in the heart that will cause the heart not to function properly. Okay, and then that's how you end up with failure of the heart. Now, if in an event, the index event is removed, okay, like I explained in recovery, if the index event is removed and permanent damage has not yet occurred in the heart at the time the index event is removed, then the patient can actually recover and function normally. But a lot of the time, after the index event, some permanent damage would have occurred in the functioning of the heart, in the structure, in the microstructure, okay, that would, in such a way that the heart would be able to sustain itself in a normal resting condition. But when the heart is exposed to stressful situation, the patient will decompensate, okay? So for instance, a patient would have had, an acute episode of heart failure, treated, they've recovered nicely. And then because that permanent damage is there, and then they have, for any reason, they go into severe anemia and more work is demanded from the heart. Because of that permanent damage that is there in the background, the heart will not be able to meet to the demand of the system in the state of anemia. Then the patient will decompensate. Or say the person contract a pneumonia, community-acquired pneumonia, causes fever, causes inflammation, and all, increase the heart rate, increase oxygen demand of the heart, and all, and the heart has this underlying damage that has been there. So the heart will not be able to rise to the occasion, and then the person will decompensate. So the main thing is whether that index event has caused a permanent damage or not. If a permanent damage has not been caused, the patient can recover fully and they are free. But if some permanent damage has been occurred, there is always the potential for the patient to decompensate once any situation puts stress on the heart or increase the demand for cardiac output, then the patient will decompensate.
Okay. Thank you so much, sir. Thank you.
Further comments, further questions? Thank you, Dr. Ajayi, for that very good question. Further comments? Further comment, please. Dr. Conte, you spoke about
thank you very much, Dr. Conte,
all right,
for that very detailed. Can I go ahead?
Please go ahead.
Okay. Thank you for the detailed presentation. Thank you very much. I wanted to find out something. You know, in heart failure, there's like a down regulation, even though there's increased activity of the sympathetic nervous system. There's like a down regulation of the adrenergic receptors in the heart.
Yes.
Is this some sort of compensatory mechanism?
Okay, so the
Sorry, did you get the question?
Yes,
Okay.
yes, I get your question.
Okay.
The down regulation of the sympathetic receptor, like you mentioned, it's actually a form of compensatory mechanism. Okay, but it is the down regulation of the sympathetic receptor is happening in the heart, but because of the excess stimulation of the sympathetic nervous system, even though the receptors are down-regulated, you're still getting the deleterious effect of the sympathetic nervous system in the heart. Okay. Despite the down-regulation, it is not enough to prevent the damaging effect of the excess sympathetic stimulation. Because remember, the sympathetic system and the renin-angiotensin system, they potentiate each other. So stimulation of the sympathetic stimulates release of renin and conversion to angiotensin, and angiotensin 2 also does presynaptic stimulation of more release of norepinephrine. So despite the downregulation of the receptors in the myocardium, it is not enough. You still have a lot of circulating norepinephrine still producing the deleterious effect of your sympathetic stimulation on the heart.
Okay.
Thank you so much.
Okay, thank you.
Dr. Jacqueline, any more? Is it clear for you, please?
No, none that I can remember this time.
Yeah. So
Thank you.
Dr. Conte, thank you so much. The proteolytic effect of your angiotensin 2, the proteolytic enzyme, you say clears it to produce angiotensin 1 to 7, angiotensin 4, and angiotensin 4 and 1 to 7. So I'm asking, the angiotensin 1 to 7, is it? Yeah, maybe this slide.
Yeah. No, not this one.
Not this one. I think after this.
Yeah. Yes. Yeah.
Yeah, this angiotensin 1, is it the same angiotensin 1 that we are aware of that comes to angiotensin 2, or is it different?
It's different. This is actually, are you seeing my cursor? This is actually angiotensin 1-7.
So
it's totally different. So you have angiotensin 1, angiotensin 2, angiotensin 3, angiotensin 4, and then angiotensin 1-7.
Yes. You spoke something about the angiotensin 4.
So you see, so these are all fragments. So these are the active fragments. When angiotensin 2 is degraded, these are active fragments that can result from degradation of angiotensin 2. So 3, 4, and then 1 to 7. Okay. Well, actually, it's 3 and then this 1 to 7. that are useful in the cardiovascular, that have useful cardiovascular effects. They can cause vasodilatation, reduce apoptosis, reduce hypertrophy.
So now my question is, why can't we get a drug that would help in production of angiotensin 3, angiotensin 1 to 7 that has vasodilatory effect and anti-remodeling effect? I'm just thinking out loud. If it has that benefit, that in degradation of angiotensin 2, we have some benefit.
Yes, yes. So that happened. And when angiotensin 2 is produced, these enzymes are there to degrade it. Okay. Now, for you to get this metabolite, you have to get angiotensin 2 first.
Yeah.
Okay. So if you in these ones, inevitably you're going to have to be producing a lot of angiotensin 2 because you are getting these active fragments from angiotensin. If the angiotensin 1 receptors are there, their harmful effect outweighs the effect of this active fragment. So that's why it makes more sense together with this fragment and just block the receptor through which it produces the harmful effect. So in that case, when you block AT1, you are having the beneficial of the effect of angiotensin 2 as well as its active metabolites.
Okay.
You understand?
Okay.
Yeah. If you just concentrate on elaborating these ones, inevitably you will have to elaborate angiotensin 2. And the angiotensin 2 is still angiotensin 1 receptors to produce the harmful effect, which you do not want. So when you block the receptor, you will get all of those.
Okay, that's fine. So when you block the receptor, you still have this other aspect of
all these effects. Exactly.
Oh,
yeah.
Wow.
Yeah.
Oh my God, thank you. Any further contribution questions, please? Dr. Adeyanju? Okay, Dr. Goodyear, sorry.
Okay, yeah, thank you very much, Dr. Conte, for yet another beautiful presentation. Well, I think, I don't know if I can say one or two things here. You beautifully explained it. Yeah, and I think it's not only blocking angiotensin 2. Blocking angiotensin 2 receptor can lead to the formation of these fragments as stated. But no, you've gone past the slide again.
Okay.
I just wanted to. Yeah. Now, if you block this angiotensin converting enzyme, inhibit angiotensin converting enzyme using angiotensin converting enzyme inhibitors.
Yes.
Rather than have this angiotensin 1 being converted to angiotensin 2, you have another enzyme that act on it. This same protease will convert the angiotensin 1 to angiotensin 1 to 9 fragment, which is also a potent vasodilator. So that is another pathway that we can actually get this one, and as well block both the angiotensin 1 and angiotensin 2 receptor
receptors.
Yes, both receptors. So going by this one. So and the angiotensin 1 to 9 have almost similar effect with the angiotensin 1 to 7 when it comes to their effect as to vasodilatation and the rest, and acting on. Yes. So yes, sir. So I don't know if I should go backward. I think the phenotyping of this you had failure with preserved ejection fraction or mid-range ejection fraction. I don't know. Yeah, I think it's an older. I think you used the 2016 guideline, right? Because the 2021 and even the recent one that was released, they take the cutoff as the heart failure will reduce ejection fraction from less or equals to 40. Then with mildly reduced, they take it from 41 to 49. And preserved ejection fraction is greater or equals to 50. So to avoid the
okay.
Yes,
I
sir.
see. I get what you're saying. Yeah,
Yes, sir.
yeah.
So I needed to. Okay, this is to add also here that I think if you check the American College of Cardiology and American Heart Association guideline, they have this heart failure with improved ejection fraction as added, though even though this one was not. So that is actually to say you had individual who initially was seen previously had heart failure with reduced ejection fraction. You've done some treatment, and then the heart failure have gone either to mildly reduce or gone to a phenotype of preserved ejection during echo. So you can classify such patient as heart failure with improved ejection fraction. So that is what the American have added.
Yeah.
One of the questions you have answered.
The thing with that with improved ejection fraction, you have to make that that classification based on your follow-up data. You have to have you cannot meet the patient the first time and make that diagnosis. You have to have follow-up. Yes.
It's true. So I was wondering, there's this N-type pro-BNP that is used as prognostic marker when it comes to heart failure. I don't know. Yes. So here, I was listening if I could hear how it's come about, and why is it that deleterious, or is just being used as a surrogate to be able to say that actually the patient have had the heart failure for a protracted time, since the processes would have led to production of a lot of BMP, which would have been degraded, however, by the neprilysin. But however, since the NT-proBNP is being excreted by the kidney and the excretion may not be that fast as the degradation of the proBNP, that would be just to have eye onto the level of the production of those BMPs, and not that the N-terminal proBNP on its own really affect the heart as per se. I don't know exactly whether you have any more information on this NT-proBNP as to why it is used as a prognostic marker.
Yeah. So when you look, it's actually the N-terminal before the BNP becomes active. When it is secreted, it's secreted as a pro-BNP, and then the N-terminal is cleaved to form the active form. Okay, and then that active form is what is degraded. So the N-terminal, because as you said, it is not rapidly excreted in the kidney compared to the way the BNP is degraded, that that N-terminal can stay in the blood for a protracted period of time, and it can give you a reflection of the amount of BNP secreted over a period of time. And remember, in here we said that BNP is more stimulated when you have as a response to chronic increase in atrial or ventricular pressure. All right. So because the N-terminal also is not excreted very fast, it stays in the blood for a long time, and then it gives you a reflection of how much BNP has been secreted over a period of time. And it can be a good surrogate to determine how much stretch is happening in the myocardium. And that's why it is useful to make a diagnosis, especially when you have heart failure with preserved ejection fraction.
Great. Thank you. Thank you very much, Conte.
Thank you so much, Mr. President. Thank you for that beautiful contribution and enlightenment. Is there any other person before we close the class? I called on Dr. Tia Andrew for a vote of thanks, if there's nobody.
So sorry, please. I wanted to just raise something regarding the guidelines. Heart failure with reduced ejection fraction. We know the drugs that you recommend, the loop diuretics, and then the 4 drugs that are used. However, even though heart failure with mildly reduced ejection fraction is, so to say, also heart failure with reduced ejection fraction, it's more like the drugs that are recommended, at least from this most recent guideline, is the loop diuretics and then the SGLT2 inhibitors, which are class 1 indications in managing them. So I'm just wondering, what is it that there was a study done? What's the rationale really? Because it's more like the treatment now is similar to how you would manage a patient that has preserved ejection fraction. Is it that a study was done that says, okay, those with mildly reduced ejection fraction, you have it's shown that loop diuretics, SGLT2 inhibitors are clearly beneficial in them, or what? Please, I will need an explanation for that. Thank you.
Let me try to explain that a bit. If you look at all these other medications that have been shown to be useful in heart failure with reduced ejection fraction, so from your ACE inhibitors to the beta blockers and the mineralocorticoid antagonists, when you look at the data that have been presented over the years, you notice that if you take the ejection fraction as a continuous variable, the benefit of those drugs, they are better in patients with the ejection fraction less than 35. When you go to get EF less than 35, those patients from those medications. And as your ejection fraction goes above 35, the benefits from those medications reduce, especially in the CHAM for candesartan, that those with ejection fraction less than 35, they benefit more compared to above 35. You know, before this recent classification, reduced ejection fraction was described as less than 40 of the ejection fraction. And for all of those initial studies, they showed that those who had above 40, they were not benefiting enough from those medications. When the results of the SGLT2 inhibitors start coming out, the one peculiar and outstanding factor about the SGLT2 inhibitors is that their improvements, the benefit of heart failure patient, you see it right through the continuum of ejection fraction. So from low ejection fraction, even up to preserve ejection fraction, you still get benefit. Okay, so it is based on that, based on those previous studies that have shown that when you are going towards the preserved ejection fraction, those traditional medicine, your ACE, beta blockers, and mineralocorticoid, they've not been shown much benefit. But your SGLT2, right through the continuum, they are beneficial. That's why they have class 1 indication for those people who are in that bracket of mildly reduced ejection fraction, as opposed to the other medication that you use for heart failure with reduced ejection fraction. I hope that explains it a bit.
Yes, thank you very much. One last question. I noticed that in the pathophysiology, we're more like focused on those with reduced ejection fraction. Could you just say,
Yes.
just 1, 2, 3, the major mechanisms that are involved in heart failure with preserved ejection fraction?
Yes. So there's an interesting question. It's something other presenters. The fact is that when you read the books that write on pathophysiology, they will tell you that the pathophysiology is the same for reduced ejection fraction or preserved ejection fraction. Okay? But then the question you will ask is that if the pathophysiology is the same, then why are the medications that are showing benefits in reduced ejection fraction and not showing benefits in preserved ejection fraction? You see? So I think is for the sake of simplicity and ease of explanation, we are using the same pathophysiology for both preserved and ejection fraction. The fact is that we do not have the full explanation for heart failure with preserved ejection fraction. Because what they'll tell you, there are several risk factors that contribute. So whether the patient is diabetic, they have dyslipidemia, they are obese, all of those things contribute to the pathophysiology of heart failure with preserved ejection fraction. And up till now, it is not fully understood. Okay? It is not fully understood why those other medications are not benefiting heart failure with preserved ejection fraction. But from the textbooks, they will tell you that the pathophysiology for both of them is the same. But clearly, the medication that are showing benefit in reduced ejection fraction are not showing benefit in preserved ejection fraction. Okay? So even with the SGLT2 inhibitors, you know, what we know about the SGLT2 inhibitors is that they cause excretion of sodium together with glucose in the kidney. That is the fundamental mechanism of action that we know, okay? And that is what we use to explain their benefit in heart failure. But with the beneficial effect it is showing across the continuum of heart failure, it is very, very much possible that there are other mechanisms of action of the SGLT2 inhibitors that is producing these beneficial effects. And those are actually under active research now to answer those questions. Okay. But the bottom line is a lot about heart failure with preserved ejection fraction we actually do not know when it comes to the actual mechanisms that go on in the heart.
Thank you so much, Dr. Conte. Dr. Jacqueline, is that clear? Or do you want to say more? Dr. Jacqueline?
Oh my God, I thought you were hearing me. Sorry.
No.
I was saying that I thank you, Dr. Conte. I was saying that I've also had, this issue of trying to get the distinct mechanism in heart failure with preserved ejection fraction, and I've not really come across anything much except for I think a literature I came across that said that one of the major mechanisms in heart failure with preserved ejection fraction is the fact that there's poor calcium handling, both at the level of the vasculature and in the hearts, such that there's now like an excessive, like that's the excitation contraction mechanism, that's the mechanism of the coupling and uncoupling is now disordered because of that, and causes the hypertrophy, fibrosis, and diastolic dysfunction that is seen in heart failure with preserved ejection fraction. That's basically what I came across for it. Then for the SGLT2, I've also come across a literature also that mentions something about the fact that they consider the possibility that the SGLT2 inhibitors may have an effect on these advanced glycation products, which may have effect on the hypertrophy and the cardiac remodeling. That might also be a mechanism by which they are beneficial in patients that are being managed for heart failure with it. Thank you.
Okay, yeah. So concerning the calcium handling, of course, we explained that during the previous discussion that once you have increased calcium in the cytosol, there is impaired relaxation. Okay, because the more calcium you have in the cytosol, you have persistence of your cross linking. And so the heart does not relax properly. And interestingly, even in heart failure with reduced ejection fraction, all patients with heart failure with reduced ejection fraction have diastolic dysfunction. They have impaired diastolic field. It's just that when they have reduced ejection, the effect of the reduced ejection fraction, it reduces systolic function, outweighs the effect of the diastolic dysfunction. But all heart failure patients have diastolic dysfunction. Okay, and so that's why that's diastolic function on its own cannot explain all the things that we see in heart failure with preserved ejection fraction.
Yeah. Thank you. Thank you
very much.
So thank you so much. So Dr. Conte, if I may ask one more question before we call on or anybody first. So would you say that in preserved ejection fraction, we should only emphasize on SGLT2 inhibitors and forget about the others since they don't have benefits? So we should stop
you know, before the Emperor Preserved and the liver trial, you know, the mineralocorticoid antagonists and what do you call it, the sacubitril valsartan, even though they are not shown clear beneficial, but they are in the studies that have been done, they have shown some tendency. They've seen some secondary benefits, benefits in their secondary endpoint rather than the primary endpoint. So before we got clear evidence of the SGLT2, they were recommending that you use the mineralocorticoids and those essays. So those recommendations still stand, but as a +1 recommendation, you go for the SGLT2 because they have shown benefit in the continuum of ejection fraction, the whole continuum. Yeah. So, and then looking at the patient mainly with heart failure with preserved ejection fraction, you want to especially address the other risk factors. So if they are hypertensive, you want to make sure you use good antihypertensive to get the blood pressure under control. They are diabetic, you get good glycemic control. Okay, they are dyslipidemic, get that under control. They are obese, try to correct the weight. So you address the risk factors as well to be able to improve their outcome.
Thank you so much. Any other person? Any question? Dr. Chibuke Ozo, are you there?
Yeah, I'm Chief. Good evening.
Yeah, good evening. It's been long. We missed you. You were supposed to give us a presentation. I'll get to you in the page, right? But thank you for your comments. Very beautiful comments. I just called him so that I can read his comment to Dr. Conte. Dr. Conte, Dr. Chibuke said something very nice. He said, Dr. Conte, you don't need to do part 2 exams again. You're a professor of cardiology, not just a fellow. So his comments quite excited me. So I just wanted to be sure he's I just wanted to be sure he's around before I read it. Thank you, Dr. Chibuke. And yeah, Dr. Chibuke, thank you. We have Dr. Jacqueline saying, lovely presentation, Dr. Conte. God bless you, Prof. That's Dr. Ayodeji Stephen, a very committed person in this group, saying, God bless you, Prof. Conte, for yet another professorial performance. Eberechiku said, excellent presentation, sir. Dr. Basanjo Olusengu, the former president of this country, said, thank you, Dr. Conte, we appreciate you. Dr. Jennifer is saying, thank you, Dr. Conte. I said, please, Dr. Fosu, please kindly help us with the recording so that we can chew it immediately. This kind of presentation, you need to hit it hard, as it is hot in Nigerian language. That's how we should do it. Dr. Conte, again, in the absence of any other contribution from anyone, I really want to say thank you. I still repeat that. Bless the day we pulled you out. And I'm grateful to God I'm sharing the same continent with you. Africa is blessed. And thank Ghana for training you. But I'm very sure that if I have the opportunity to use a microphone, I will tell the whole cardiology body that a bomb is coming. And that person is Dr. Conte. You're a good person. Thank you for being a good person, apart from the stuff that you have. You're a good person. Thank you so much. We enjoyed every bit of it. Thank you for the sacrifice. And again, we are looking forward to the ACLS presentation. It's going to be sweet and lovely.
Absolutely.
I wish everybody on the page. That was why while you were presenting, I had to go there and put we are live. I wish everybody should just come in and listen so that they can ask questions and get clarified. Because listening to ask real life questions. With these few words, I want to say thank you, Dr. Conte. Please extend our regards to your wife. Thank you. We also must have given you time. She must have she must have given you time to be able to present and do this detailed work. Yeah. So our regards to Ghana and to everyone. Dr. George Afonso, thank you. Thank you, Dr. George.
You're welcome.
So
to say thank you for everything, and it's nice hearing that you have your wife not like my friend Kopi that have refused to marry.
Don't worry, Dr. Conte, I'll invite you to Nigeria for my wedding.
I'll be obliged. I'll make it a point of duty to attend.
Okay, thank you so much. I'm so excited. All right, class. And also, I want to thank everyone, please, for the beautiful discussion we had to suspend the class until after NCS. And I also want to thank our participant from Ghana for accepting that sacrifice. Please, we are grateful. Thank you again. Thank you. Please, we'll commence by Monday. For now, we'll be off. Okay. I'll paste the information on the page. God bless you. Please have a great evening, everyone.
Thank
you.